Good morning and welcome to day 2 of our virtual wellbeing festival. Hello, my name is Anne Linsell from Northamptonshire Healthcare, and my role today is to facilitate this virtual wellbeing festival live session. I'm supported here today by colleagues shown on the screen. We are all here to facilitate and support the session, which is understanding grief reactions, and ask any questions that you may have of the presenter. This live event is a series of a wide range of diverse events running across the week as part of our Northamptonshire Health and Care Partnership Virtual Wellbeing Festival, to give us all tips and tasters to help our health and wellbeing as we continue to work through this pandemic. Before I introduce our live session, Understanding Grief Reactions today, I would just remind you that if you have any questions for the presenter, please put them in the question box and we will do our best to answer them at the end of the session. You can also like questions asked by others. Already within the questions, you will find a link for you to provide us with your email address so that we can send you a link for feedback directly after the event. We really want and value your feedback. Our session today will run for about 60 minutes, and today's session is led by Trudy Robertson, an IAPT therapist from the Changing Minds team. The session will provide an overview of grief reactions and will include bereavement-related depression, trauma-related grief and prolonged grief. So without further ado, I'd like to hand over to Trudy.
Thank you, Anne. So good morning, everyone. So as Anne has introduced the session today, coping with depression and trauma-related grief. Next slide, please. So it's the session today. We do welcome questions and comments, but we're sort of giving an overview of sort of trauma and grief reactions and depression. This is a difficult subject, so you may be aware that things do become upsetting or overwhelmed as you're starting to make connections for yourself or perhaps somebody that's in your world. It's okay to absent yourself if things become too upsetting, but do try and come back to us if you can. We've got some support numbers at the end of the presentation, and at the end of the presentation today we've got various supports and websites for bereavement help. Next slide, please. Okay, so our aims is we're going to be understanding more about grief. We're going to start to explore the difference between normal grief reactions, bereavement, related depression and traumatic grief, when to seek further help. I'm going to give an overview of our IAPT Changing Minds interventions, and towards the end of the presentation we're going to be looking a bit more of general self-care whilst grieving. Next slide, please. So what is grief? So grieving is a process of adjustment, a natural response when we've lost somebody we love or regard dearly, or for some of us it may be that we've had a difficult relationship with the person that's died. So the intensity of the grief presents in very different ways for each of us as individuals. Some of us experience it very emotionally, some of us may have very strong physical reactions, or sometimes an absence of physical connection, and it may affect our spirituality. So often grief is a very sudden and intense reaction. Certainly in those early days that can be very common, or that intense reaction may be an absence of feeling for quite some time. But as we move through different stages of grief, our emotions can change and move in different directions, and we may experience a number of emotions, thoughts and feelings that go along with that. Next slide, please. So this slide is about giving an overview of common symptoms, reactions that people may present with, and you may identify with some of these, or you may identify with just one or two, or all of them. So just going to give an overview really. So some of us may have strong physical sensations. So we may experience, a persistent hollowness in our chest, our stomach, or we may experience a lot of tight feelings, breathlessness. Some of our reactions may be, lacking in energy, feeling tired all the time, sleep disturbance, sleep difficulties. Our emotions, we may experience some of them or many of them, so we might move through feeling numb, shock, sad, anger, guilt, relief for some of us as well. Some of our thoughts may come and go. We may experience strong disbelief, it can't be real. We may experience a strong preoccupation, either it's my fault or blaming other people. Some of us may experience hearing their voices, seeing images, sensing the person, sensing their presence. We might spend a lot of our thoughts searching for meaning of life and death. We may even dream about the deceased. Some of our behaviour, we may avoid more than we normally would. We may suppress our thoughts, feelings and reactions. We may over-distract with activities, things like cleaning, organising, or some of our interests may stop altogether. We may appear okay, or sort of new behaviours, new coping responses that aren't normally part of our pattern, things like excessive shopping, drinking, taking drugs. They may all be common reactions of grief. Next slide, please. So there may be some misconceptions out there, and it's just important to perhaps take an overview of that. So there's misconceptions that everyone goes through the same stages and feels the same when grieving. Distress will go away if we try not to think about it and keep busy. It's important to keep strong. Often that can be quite helpful at the very beginning, particularly if we're thinking about other people at this time. But sometimes actually keeping strong may delay our own grieving response. Crying spells, this idea that if you don't cry, it means you doesn't care. Some of us, as we've identified, may experience shock, numbness, disbelief. So crying may come along at a different phase of our grieving. Grief is felt after the loss, and grief brings people together. These may not all be your experience. Next slide, please. So I'm going to say a little bit more about the grieving process. So grieving takes time. There's not a set period of time to grieve and complete grieving. Normal grief reactions is thought to be around a year. So this opportunity for us to experience all our firsts in that timeline of grieving. But it's important not to limit your own grieving time by these thoughts that may come and go. I should be better by now. Others are better, why aren't I? It is different for all of us. It's important to allow yourselves time to grieve. Be patient with yourself. There will be good days and bad days. Some people may try to avoid grieving, not thinking about it, not thinking about the person, distract themselves. But this may contribute to grief being delayed, and that may mean that it resurfaces later. And this is where we perhaps start to think about depression, vulnerability, or trauma reactions, as the distress may be maintained and surface a bit later on. There may be other factors about how we grieve, or things that may affect our normal grieving, our culture, our age, gender, religion, our past experience, the supports that may or may not be available. And certainly over the last 3-4 months, support systems, the usual things that we do around coping with our emotions, thoughts, feelings, people around us, we've not necessarily had access to other people that are important to us that would perhaps help and understand because of COVID lockdown. So there's certainly things that may be affecting our normal grieving process. So our grief may be delayed and maintained because of these reasons. Next slide, please. So stages of grief. So this is a really sort of well-known Kubler-Ross model, stages of grief. There are other models that are really helpful. So again, we recognise that stages are not rigid or linear. We may not go through all the stages. We may not go through any stage in any particular order. It's really common that we actually might go back and forth across our stages of grieving. Again, try not to worry about what stage you should be feeling or what stage you're in. And you may have awareness that other people may be in very different stages. As again, we're learning that grief is individual and it's not the same for all of us. There's no typical response to loss. There's no typical loss. It's as individual as our lives. And next slide, please. So one of the stages in the Kubler-Ross model is shock denial phase. So it may be very common that we may recognise our thoughts. This can't be happening to me. It shouldn't be happening to me. Often when we first hear the news, we may feel numb and not believe it's happened, even if for some of us the person's death is expected. It's a normal reaction, this sort of shock denial phase, and it can be our psychological attempt to protect us from the extreme feelings that we have. We may be very overwhelmed and distressed in very sort of significant and severe ways. So we might feel this sort of disbelief, unable to, or we may be unable to stop crying. So this is a very understandable phase of our grieving. Next slide, please. So anger phase, we may have a very strong anger reaction, sometimes called a protest to the news that we're hearing. Whatever stage this may, you may move into an anger phase. It is normal to feel angry in our daily life anyway. Anger is a normal human emotion. It can be particularly difficult when we are grieving, and it can occur at any point in our grieving process. It could be aimed at ourselves, strangers, family, or even health professionals. It may even be directed towards the person that's died, which can then contribute to other difficult emotions, things like guilt, embarrassment, ashamed. So this may affect how we express our feelings, who we talk to, who we confide in. So this may be one of the things that could lead us to sort of having vulnerability to other psychological reactions like depression or trauma. Next slide, please. So bargaining. So this is often a stage, it can often be sort of acknowledged as this sort of disorganised, frantic phase where we're trying to reason with our loss, but we still may be moving through different feelings, reactions. So we might start to believe it, but then our painful emotions and thoughts come back in, sometimes in an intrusive way. So we may start to say things like, you know, if I do this, then it might not happen. So we may start to experience some quite strange patterns of thinking that feel odd and outside of our usual. So we might become over focused on what could have been differently, what we could have done, what others could have done, and this may prevent or delay the recognition of the loss. Okay, next slide, please. Sadness. So sadness is, again, a very understandable and significant symptom of grieving. Other feelings that might go along with sadness, helplessness, emptiness, loneliness, are all part of sadness. Everyday things may trigger our sorrow or our yearning. Lots of common things, it may be sounds, adverts, smells, places. Just looking outside our window may cause these very strong reminders, and including the strong reminder of our loss, our sadness. So sadness may mean that we start to withdraw more, avoid people, avoid things that we usually do. Struggling to eat, sleep, concentrate are all very common when we start to feel this intense or prolonged sadness. We may decide to spend time alone, and this may help us in reflecting on our loss, but it also may mean that we overthink our memories of the time that we spend together. So this may be useful, but it could also be a contributing factor to distress that may link in with depression or anxiety and trauma. Other emotions can be associated with sadness again, a bit like the anger phase, feeling guilty for things that we miss, this sort of future sadness of things that we won't be able to do together. So again, this prolonged sadness that may lead us to have sort of depression and anxiety vulnerability. Next slide, please. So often regarded as our final stage of grieving, this acceptance phase. This is where perhaps we can start to see that we're becoming more organised and we're realising we're moving towards this sort of new normal, rebuilding, re-engaging in our day-to-day living with ourselves and with other people and the usual things that we do. We may start to find pleasure in things again. We may start to experience a sense of peace without the person that's no longer in our lives. At this stage, it may be easier to remember the happier times, and that doesn't necessarily provoke a distress reaction or intense sadness or these other intense emotions. You know, it is reasonable to say that for some of us that may happen earlier in our stages of grief, but it's often becomes more real and more felt and part of our acceptance phase. Loss often means our values have changed and we start to find new meaning in our life, whatever that new life might look like. Okay, next slide, please. So we're now going to start to look at grief and depression reaction and start to understand what is similar and what are some key differences that may help us wonder around that important question. Am I also starting to become depressed? So grief and depression are different. It is possible to grieve without feeling depressed. However, some of the reasons why we do experience depression may be things like because we've already got a pre-existing depression pattern. So if we have that history of depression, we may just have that vulnerability. Sometimes it's important to recognise that if we become depressed quite early on in our grieving process, we may get stuck in certain phases and stages and we just struggle to express our feelings that help us move and work through our reactions. Again, it depends on the social supports and the difficulties that we have using our usual supports. You know, churches and our access to our spiritual support and our religious support just aren't as available. Our own sort of value base and our network just hasn't been around as much in recent months, and that has been quite a prolonged period now. So that just may be extremely difficult and a contributing factor as to why we can't work through our thoughts and feelings and process things in the usual way. It may be that we did have a very difficult relationship with the person that we've lost, and now that they're gone, again, we may struggle to express our thoughts and feelings, and we may inhibit those as it's not often regarded as the usual thing that we do and say. Often other people may have had a very different and may have had a positive relationship with the person, so therefore we feel outside of what are typical reactions where we can idealise the person that we've lost in those early stages of grief. So we can feel really isolated. Perhaps our depression pattern may be because the death is sudden, unexpected, or even maybe traumatic. And there may be other complicated or prolonged circumstances around the death. And again, the COVID situation and the prolonged lockdown and not being able to see care or support has been absent for many of us. Okay, next slide, please. So I just want us to take a moment to have a look at this slide where we look at what the similarities are. So just take a moment to work through the key points that are made in this slide. Just take time to see that it's very, very similar. So it may be really difficult to acknowledge that perhaps we have become depressed. So, you know, the bereavement reaction and depression have got a lot of common areas. So we're going to start to look at the next slide, please, and this will help us look at what some of the key differences are in being able to understand some of the differences between depression and grief. So with depression, the feeling is often ongoing and persistent. So whilst there may be some fluctuations, it is persistent and it's ongoing, and it can start to become very general. Whereas within grief, key things like sadness will decrease over time. Sadness may be waves and it resurfaces with certain triggers or reminders. With depression, there may be more generalised feelings of guilt across other areas of our life, whereas with grief, it may be more specifically associated to the loss itself. With bereavement-related depression, the focus is on feeling isolated and alone, and again, that may be much more general. With bereavement and grief, it's feeling lonely because we miss the person, so we can acknowledge some of those differences. In depression, lack of enjoyment and pleasure in most activities across various areas of our life, social and our own private leisure. Within a grief reaction, we're struggling with the pleasurable activities that may be missed because of the person that perhaps we associate with that pleasurable activity, but also we may start to continue to pick up and experience pleasurable activities once again, whereas it may remain unchanged over a greater length of time with depression. We may experience suicidal thoughts in grief and in depression, but the thoughts in grief may be more about wanting to be with the person that's died, this sort of longing and missing of the person. Feelings of hopelessness are common across both, but with grief we perhaps start to feel more hopeful without the person as we're moving through our stages of grief. Whereas in depression, that helplessness pattern may persist and remain unchanged. Okay, next slide please. So some key messages. We're starting to look at the similarities and differences between depression and grief, but start to think about how we deal with them differently. So typically when we feel sad or negative because we're depressed, in our evidence-based depression treatments, we would recommend that you start to do something, get activated to shift our mood. Speak with someone, go for a walk, do something pleasant, start to generate that pleasure centre of our brain. Depression is a very treatable condition, and our evidence base has very good outcomes in treating depression. We've looked at the slide where hopelessness and the persistent nature of our depressed feelings is very evident, so it's very important to have that hopeful discussion and knowledge that depression is a very treatable condition. But when our feelings are sad because of our grieving, we do think about involving yourself in your sadness, anger or other emotions to work through and start to process our grief and our bereavement in this way, doing things that remind us of the person, activities, photos, share stories to help you work through the stages of mourning. And next slide please. So I've already sort of mentioned diversity and culture and religious factors, cultural differences, spirituality. These are all really important aspects that help us work on our grief and are important in understanding our psychological reactions like trauma and depression. So it's important that we have an awareness and an understanding of what we need that's unique to us, but also may be part of our religious beliefs, our culture, our family culture, disability, developmental disorders. So perhaps where communication and our interpersonal and our emotional expression is affected by things like Asperger's or a learning difficulty, different social groups perhaps grieve and talk about our feelings in very different ways. Again, that might relate to our age or gender bias. So these are all elements that might affect how we think, feel and do, and that's relative to grieving and depression and trauma. Okay, next slide please. So the next few slides we're going to start to look at grief and trauma reactions. So in understanding traumatic grief, the person's experience is and usually remains very intense, very overwhelming and persistent. The person can seem very, very stuck, and we may feel very, very stuck in that state they immediately experienced after hearing the news of someone's death, even if it was expected. So we can start to acknowledge that particular symptoms associated with trauma, intrusive images, thoughts, feelings linked to the person and their death. We might experience strong negative beliefs such as I'm to blame. We might experience that in an intrusive way. So it's this sort of continuous dialogue that goes on in our mind. I should have done more. And there may be this persistent strong avoidance and intolerance of the associations associated with the deceased. And of course, that's often something that's very much around in our everyday life in the days and hours after, and the months, while we're organising and trying to get things done as we're moving through the usual things that we attend to once a person's died. And next slide, please. So again, we're going to start to look at the similarities and at the difference. So within PTSD reaction, so post-traumatic stress disorder, it's the primary emotion here is fear, this very strong threat response associated with fear. So the prevalent emotion is fear and anxiety, and it's related to those specific memories associated with our event. We may experience nightmares, painful specific reminders that really do generate that very strong fear threat response. High avoidance and this hypervigilance, hyperarousal, this on edge, often this startled response. It's very demanding of our body, and we've already learned that we tire easily, we may fatigue, our muscle groups may very much be on edge, it's hard to switch off. So in grief, this prolonged grief, so it's driven by loss, but the prevalent emotion remains fearful and strong sadness. These very painful reminders, pervasive and unexpected again, yearning, this yearning feeling of the loved one, anger, denial. We, again, as we've said, we may experience this stuckness reaction. Another symptom with prolonged grief, we may also experience for ourselves some of the perhaps the symptoms that the person experienced during perhaps a period of illness or some of the cause of death. We may start to experience some of those thoughts about ourselves, and when we may become health focused ourselves, that may be a sign of stuckness in our grief reaction. So some of the similarities, the memories resemble trauma reactions, again, intrusive flashbacks, images, sensations. We may relive these. Avoidance of the memories associated with the deceased. So of course, we're not going to process our thoughts, feelings and reactions. The feelings are very, very intense and pervasive over time. And we've already understood in grief reaction, usually as we're working through the stages of grief, there is start to see a shift in what we're reacting to, and we start to adapt in a more useful way to help us move to that acceptance phase. Here in trauma, we're just unable to do so. And next slide, please. So some of the key messages here, there is in trauma reaction persistent reminders and distress around the death itself and the person's experience of the death. Particularly, we might start to have thoughts, feelings and reactions about the attachment that we had, the relationship that we had to the person, perhaps any conflicts, and perhaps thoughts about what it means for us, how it changes us. That may also form part of our distress reaction. So when this very important attachment figure disappears, the response is intense. This strong emotional protest, as we've acknowledged in our grief cycle. So we may feel despair, disbelief, anger, intense sadness. So it's often quite useful to regard this period as an acute stress reaction, and commonly we understand this in the first 8 weeks of a very difficult life event, and usually after this time we might start to be able to work through. If we're not able to work through, then after that 8-week area, then perhaps PTSD, this traumatic grief reaction is indicated, and we may need to start to think about how we support people with that distress reaction. So the grief interferes with the trauma processing. Okay, next slide, please. So we now have a diagnosis. There's two sort of diagnoses that we usually work with. So the DSM, the Diagnostic Manual, and our ICD-10, so our International Classification of Disorders. So we now have prolonged grief disorder. So the prolonged grief shares some similarities to depression. So again, the immediate grief reactions persist over time. The intensity remain undiminished, causing considerable impact on everyday functioning. So that's how we start to think about this as a prolonged grief disorder, this impact on our everyday functioning, and it remains undiminished. So usually we can start to think about a diagnosis after around 6 months. But we do know that normal grieving can be up to a year. So again, and that can still include, you know, increased and waves of strong emotions like sadness. So we don't want to start to think about this as abnormal, but an unresolved sort of grief reaction. So there is little observable change or flexibility about how the grief is being handled. So we're not moving through those stages of grief. Intense longing or preoccupation, very difficult to accept the death. A really important symptom that I've seen quite often in people, this idea, this feeling that they describe that they've lost a part of themselves. So they can't rebuild and re-establish because they're not themselves, they're not whole, so they can't take that forward into their new normal. So there is difficulties in continuing with their own life and seeing that as valuable. Again, emotional numbness, emptiness, perhaps things like derealisation, dissociation may feature here, that they're just unable to be in the reality of the loss. So strong avoidance of places, so things remain unchanged because these are strong reminders. Persistent rumination around how the death could have been avoided, self-blame, blaming others are often at the centre of this prolonged grief disorder. Okay, next slide, please. So we're going to start to think about the help that's out there and when to start thinking about depression or trauma reaction. So if you find yourself being able to identify with some of the depression symptoms or some of the trauma reactions in this workshop, then you might start to recognise that your grieving process might have become stuck, and it could be really important to seek help in the form of a psychological problem or counselling, or access some kind of support or a different type of intervention. So perhaps here in our evidence-based treatments, we might think about medication like an antidepressant treatment, which is one of our first-line treatments for anxiety and depression. So I'm going to outline a little bit more about what IAPT Changing Minds offers, and at the end of the slides that I believe you have access to afterwards, I've listed a number of organisations that can provide support for you at this time, or perhaps, you know, could be helpful to a friend or a family member, or even a colleague. Okay, next slide, please. So I'm going to start with some of the IAPT Changing Minds interventions. So we have a self-referral system, so you don't have to go to your GP. You can do this yourselves. There's a phone number, or you can use one of our online referral systems. So you'll have an initial telephone assessment, and we start to support you in sharing your difficulties, your problems, and we start to help you think about goals. What aims do you have about seeking a psychological intervention? So some of the possible options that you may discuss at the end of your telephone assessment. So we have low intensity guided self-help, CBT, so that's cognitive behaviour therapy. And this is offered in a variety of ways, face-to-face, groups, or our computerized cognitive therapy program. We are still offering face-to-face, but that's now delivered through our remote working. So we do our video sessions, and that's working really well for most of us. We do have telephone option if that's your preference. We have webinar courses, so these a bit like this, so it's a live online session, and we have courses around low mood, improving anxiety, stress reduction. We do have a post-traumatic stress disorder webinar if that's indicated, so that's usually whilst you are waiting for a more intensive therapy if PTSD has been indicated after your assessment, maybe some initial interventions. So I'm going to share a little bit more about our intensive treatments that we offer. So we have 3 depression treatments and we have 2 trauma-focused interventions. So we have interpersonal therapy for depression, CBT, and that's for depression and trauma. We have counselling for depression, and we have EMDR, eye movement desensitisation reprocessing, a trauma treatment. Again, there is medication, which is one of our first line interventions. We have other supports in our service. We have a peer support, which is a listening ear. They can be really useful as well in practical problem solving. And that may be really important when we're faced with, you know, a volume of phone calls, organising and sorting when we just don't have the energy or the motivation to try and resolve those, and we just don't know who can help deal with some of those practical issues. So they can be very useful to direct us or support us in finding out where to go for that. Part of the assessment, or even if you've been through some of our treatments, we may still support you in a signposting option. So perhaps to support you with continuing your normal grieving, perhaps through Cruse or other bereavement related organisations. And next slide, please. So I'm just going to give an overview of some of our depression focused strategies in a little bit more detail. So CBT and interpersonal therapy for depression is usually between 12 and 16 sessions. So it's quite an intensive commitment, and we do treat mild to severe depression within these 2 treatment models. Both models are structured and directed based treatments. We actively involve you in your treatment to develop and work through the strategies that we're sharing and helping you to develop. A key element of both of these treatments, and as we've referred to earlier, is activation, re-establishing your ADLs, your activities of daily living. Really key here is reducing avoidance, rebuilding that emotional connection to improve social functioning in your own private leisure functioning. Particular with interpersonal therapy, if bereavement is within the last 5 years and it does seem to be linked to your depression episode, then we do have a particular bereavement related focal area. So there's very specific strategies that support you in working through your depression to help you get back into your grieving rhythm again, your grieving needs. If the bereavement is over 5 years, then one of the helpful areas is what we call role transition, because your identity, your functioning may have changed quite significantly depending on the nature and the impact that the bereavement had. So this area can help you to re-establish areas of your functioning that have changed or have been lost. So the next other depression treatment is counselling for depression. Again, it's up to 16 sessions, but this is for mild to moderate symptoms. And what we recognise in this counselling approach is that there is the focus is on emotional connection and helping you connect with the underlying feelings, making sense of them in your depression. And we've learned in grieving and with depression, it's about finding new meanings. So this could also be a very helpful treatment for your depression. Next slide, please. So an example of a vicious cycle to moving forward. So there may be a number of typical thoughts that can repeat and be very common or be very intrusive in our sort of depression. So we might have things like, you know, I shouldn't feel happy, I shouldn't be enjoying myself, I'm a horrible person, for thinking about a life without the person that we've lost. So this understandably is going to maintain our emotional patterns, so guilt, sadness, feeling low, which may maintain and keep our mood going and feeling worse. So the common behaviours, the common coping is that we may isolate ourselves and withdraw, and we struggle to go out and do the things that are going to lift our depression pattern. So next slide, please. So behavioural activation, or our antidepressant activity, that's very common. First sort of step in our evidence-based treatment in the lower intensity interventions of CBT and in our CBT and IAPT model. So we've learned that depression isn't just about feeling bad. There are many, many other feelings that go with our depression reaction. So we understand that activity can help us feel better. Having something to do gives us a different focus. That gives us the possibility that we can start to experience other sensations, feelings, thoughts if we're engaging in a different activity. So it might start to help us feel that we're moving forward, taking control of our lives, even in a small way. And we're going to start to give us the possibility of generating this pleasure centre. So what we know in depression and trauma are feel-good hormones. So these are often called neurotransmitters. They alter and change, and it's more difficult to get this back into our brain biology, our serotonin, our endorphins, our oxytocin. So even if we don't feel like it, it's really important that we activate that part of our biology, and this is, you know, very strongly linked with what's maintaining our depression. So starting to try and do activities that are associated with enjoyment and or sociable is going to start to help us. If we're doing these activities, then perhaps the biological feelings of depression, tiredness, no energy, can't get going, sleeping too much, may start to alter and change as our depression pattern can start to lift. So we know when we are physically tired, ill perhaps, rest can be important, but when we're depressed, the evidence base tells us that the opposite is true. We need to get activated to generate these feel good and sensations, physical sensations that can help us keep going with our activities. Activity can help us feel and think more clearly. So once we get started, our perspective can start to develop. So we may get problem solving to start to become more effective again. By having a different focus, it can rest our distress so we can start to think in a clearer way. So next slide, please. But we know getting active takes time, and we know it's not easy to even think about doing things that have stopped, doing things that with other people, particularly if there are still reminders of the person and the things that we've lost, how our life has changed. But when we're depressed, we do think, you know, we have to recognise that a symptom of depression is negative thinking. So that depression talk, I won't enjoy things, and yes, it may be without them. It's too hard, I'll make others miserable. So this may stop us from getting started. So one of the things that we have to recognise is we might try and do too much too quickly. So pacing and being selective and investing that little energy that we do have in the right things that are going to activate our pleasure centre and support us in reconnecting, re-establishing things. And it may be very basic parts of our activities of daily living, getting dressed, washing our hair, eating. That may be where we need to start. Or it may be that you focus on more of the social things, giving us a reason to take care of ourselves a little bit more. So with antidepressant activity, it's the action that's the first step. We can't wait for motivation to come back before we get started. Motivation gets going once our activities have started, as we start to make the links of you know, feeling better, feeling, even if it's small, achievement and pleasure. Okay, next slide please. So I'm going to say a little bit about some of our trauma-focused interventions. Again, we have cognitive behaviour therapy for mild to severe symptoms, again typically between 12 and 16 appointments, sessions. involves helping us to focus on our identified trauma memories and working using a reliving process to work through what we're perhaps suppressing or avoiding, but you're going to be supported in working through those intrusive memories and sensations. There is what we call a discrimination technique. So it's really important here to try and work on this update of our timeline. So we're working on what's different now and then, and what's the same now and then, to start to help us to work through the experiences of things like flashbacks, nightmares, and those intrusions, so we can start to be much more in the here and now and work through on the unresolved. Because it's been too difficult for you to work through that. So this is what we call cognitive restructuring. This is an element of that. So in cognitive restructuring, we've got various techniques that help support you to reevaluate, reappraise some of the thoughts and feelings that remain unresolved. We may support you in things like behavioural experiments to support that change work. So reducing those avoidance behaviours or things that you may be doing too much of that keep you stuck in the trauma and maybe stuck in the grief cycle. So EMDR, eye movement desensitisation reprocessing, again for mild to severe symptoms. We have a grief specific protocol that we can work through to support you with those identified memories. So it works on the idea that our brain and body are strongly linked. So we've referred to a lot of those physiological symptoms that remain very powerful as the intensity of our thoughts and beliefs associated with the loss. So they stay stuck in our threat system, in our limbic system. So the idea that we use a technique called eye movements or bilateral stimulation. So we create rapid eye movement to help us link our brain networks together. So our threat response is identified in our amygdala, which is one part of our brain, and we start to get our thinking brain back online. So our hypothalamus and our hippocampus. So we start to get those networks reconnected back, so we can start to think and feel using eye movements to start to make connections and work through our unresolved thoughts and feelings. There's a lot more to say about both of these treatments. So our PTSD webinar helps people feel much more prepared for both of those treatments. Next slide, please. So coming back to our grief wheel, so both of these, all of these treatments help us to reduce avoidance and update our memories. So we're working through denial, bargaining, sad, anger phases. So we talk through what happens in more detail in a supportive way. We identify the worst thoughts and images and we work through those, helping you talk through what happened, but updating those memories and how you want to feel now. We support people in treatment in working on those safety behaviours that get in the way, that keep us stuck, so we can move through our trauma symptoms and depression symptoms, but also get us back into healthier grieving. So next slide, please. So we're supporting people to rebuild their lives, working on that grief wheel of our acceptance phase. So starting to think about that we can't change the fact that the person has died, but we can start to adapt and we can start to live with their loss. Think about what's changed and what's stopped and start to re-establish some of those things and redefine it so it starts to fit with your new normal and the value base and your identity, living with what's changed, slowly reintroducing things, supporting you with time to rebuild activities, and working through any residual feelings that might affect pleasure and achievement of life without the person. Re-establish your social connections, and again we do understand that that can still be very difficult with some of the changes that we've had to make with lockdown, and whilst things may be altering in the phases of coming out of lockdown, for some of us we may still have our own perspectives on that. And there may still be some difficulties as our own individual family. So making adjustments to include decisions about what to keep and what to remember personal items affects where we live and how we keep our home, perhaps, building that new normal without the person. Next slide, please. So there are some general ways of coping with loss. So I think we've already covered these, but this is again about sort of general grieving. So remembering that it's healthy and it's okay to actively grieve, talking to others, particularly about triggers or reminders, anniversaries, trying to engage hobbies and interests, allowing yourself to think about the past and starting to think about some of those happier memories. It may be important to write about your loss, express your feelings in that way. Maybe an opportunity to make a tradition about how to celebrate and remember, lighting candles, planting flowers. Next slide, please. So reactions of others. So whilst we are absolutely acknowledging that reconnecting, seeking supports from other people can be really important and helpful with our depression and our trauma and in normal grieving, but we also know it can be one of the hardest things to do because our grieving is individual. We just may know that other people are really uncomfortable about your loss and maybe theirs, so they might tell you not to think about it. People may say hurtful things like you need to move on. People may not really understand the level of distress that we're in. They don't know what to say. So it's a very challenging area. Next slide, please. But again, just to reaffirm that asking for help, asking people to be there, it may just be that we ask them to listen, that we're right, we understand that they might not be able to change our feelings, make it any better for us, but just to listen or offer in a practical way may be really, really helpful to us to just start to make changes for ourselves. It's maybe a really supportive thing to do if somebody is in treatment. Still invite us out, even though we may still decline for quite some time. Next slide, please. So looking after yourself. So again, psychological well-being is really important and it's an active process. Talk to people. Grief can be about remembering the person, not forgetting them. We are, still maybe long after that first year, still in different stages of our grief, but it may take a different form. Making a memory box might be a really nice idea about how to treasure and protect those memories, that we can look through them when we feel more ready, and that may help later down the line when we're grieving. Music can be really important. Going to a place that symbolises, or a special place where we can sit and remember. It may still be really important to talk to the person that we've lost about your everyday life, still involving them in your here and now life. Next slide, please. So we've recognised both in depression and in trauma, it can really take, and in normal grieving, it can really take its toll on our body. Stress reaction, not sleeping, it may be that we struggle to eat. So it's not only emotional, but it can be very, very physical. So looking after ourselves, even if we don't feel like it, can really be very valuable in coping and reducing depression vulnerability or coming through some of those symptoms. So making time to eat, trying to stick to a sleep routine, exercising can be really important, taking prescribed medication. It's really common in that early stage of grieving, or when we do get depressed or traumatised, that we may self-medicate with alcohol, too much coffee, sugary drinks, or even taking drugs. They may affect how we process our thoughts and feelings as well, and actually may contribute to keeping ourselves stuck. Next slide, please. So a couple of resources that you may come across this week in some of the other sessions, and some that can be really helpful. I am aware of time, so I'm just going to give an overview of this. So in our service, we often teach 3 main strategies and support people in developing them. A visual strategy can be really helpful, a breathing strategy, and a body strategy like progressive muscle relaxation. We really help support people work on those because they are free and you've always got them with you. You don't have to remember them wherever you go. So a box breathing method can be really useful as managing distress or working through and reconnecting back. So gently inhaling for 4 breaths, holding your breath for 4 seconds, and gently exhaling your breath for 4 seconds. And working through that box method, maybe even visualising this space in your abdomen where you're gently being able to breathe in for 4 and breathing out for 4 and having a gentle pause. We know regulating breath isn't easy, so this simple technique isn't necessarily easy, but once we've established it, it can be really helpful to ground us back into our here and now. Similarly with the progressive muscle technique, we're working through each of our muscle groups, tensing our muscles for 5 seconds and then relaxing that muscle group for 15 seconds, switching it off or learning to find this sort of neutral sensation in that muscle group. We may do that 2 or 3 times in each muscle group and then move on to the next one. What the evidence base tells us is that it's not, both of these strategies aren't necessarily going to get the benefit of them very early, but with persistence and with practice, that you can start to experience some benefit. And the evidence base tells us that it is a minimum of about 12 weeks with regards to switching off and starting to ease that tension, that stress that we're holding in our muscle groups in the progressive muscle relaxation technique. So do try and have a look at those. They're sort of commonly known resources, so I'm sure you'd be able to find some information on them. And I'm sure that they're being talked about this week. Okay, next slide, please. And as I said, we've got some of our contact numbers and some of the useful support, particularly if you're in distress. And then the remaining slides are web information and contact numbers and information about various bereavement supports. And I'm sure you can look through those in your own time. So thank you very much for listening to the presentation today, and I'm hoping that we may have some questions or comments.
Hi Trudy, thanks very much. Excellent session, so informative and educational. We have some questions for you. I will give you the first question now. That is, how is best to support someone who has lost a loved one?
So I think, as we said, some of the key things: reach out, be that listening ear. Sometimes I think it's really important to sort of acknowledge that we may not be able to say anything, we can't take their pain away or distress, but we can be available to support, listen. We may start to think about being practical. That could be a way to feel safe enough to be let in. So it may be starting off with practical, just going around, if we are now allowed to, if that's safe to do so, putting the kettle on, just being there, sending text messages, supportive photos, just generally connection, reducing that isolation, I think can be really important. For some of us as well, it may be that sharing some of our own experience about what helped for us may start to help people feel that, our feelings are understandable and are normal, and we can be there. So that, that's really, really broad. And it could be, if you really are concerned about them, maybe suggest some help, because it may be that we're too close. So somebody outside of our sort of inner network may be really important to access. So it may be that we're just close, but help that person see that there are other supports around that can help. So I hope that's a useful response. Thank you.
Thank you. The next question that's come in is, if someone experiences trauma when losing a loved one, how would treatment be focused, and what would they need to complete? Would they need to complete trauma work first?
Yes, so trauma treatment, certainly within our service, as I say, we follow an evidence base. So we would, in our assessment phase, we would be very much identifying those specific symptoms to the person themselves. So it may be an image, it may be a thought, it may be in the form of a flashback, nightmares. So they're very key sort of trauma symptoms, these intrusions. It may be that avoidance is a very key symptom, so that may give us a clue that it is a trauma-based reaction. That hypervigilance, that hypersensitivity, that hyperarousal upon the reminders is very strong. So what we do in treatment is we don't start to work on those memories until we've done the preparation and education phase. So that's really, really important, so you can understand what's going on, what memory processes are happening and why. So we give a lot of education and understanding our threat response, our biology change. So it's really important that, you know, this is really key in reducing that sort of self-blame, that hopelessness of why aren't I coping like other people. The memory has got stuck in our threat response of the brain, so that's what we call the amygdala. So each time that we're reminded of that distressing memory, the threat response becomes active because it feels as if it needs to protect you by fight, flight, flee, or, you know, so again, avoidance or pushing against those memories may feel very understandable, but it gets in the way of us dealing with and facing the reality of our loss. So trauma treatment takes us through that, either using CBT or EMDR. So once we're ready and we're resourced to cope with the emotions, and that's really important because we know if your emotions are so strong, our thinking brain doesn't work so well. So we can't get our networks together in order to process, if you like, download the memory in a useful way. So it can go in our sort of old memory, our filing cabinet of the mind. So our service will take you through those steps so you can understand what's expected in treatment, but also how to prepare for it. So it feels safe enough. And we are doing that remotely. So even at this particular time, we're very much able to engage people in their treatment within our service, either through video sessions or through the telephone. So I hope that answers some of that question.
Okay, Trudy, excellent. Thanks so much. I think this question sort of follows on to the last question, but this is more around children. So the question is, what is available to help support children with PTSD?
That's an area that isn't so well known to me, if I'm honest, in terms of accessing the supports for children who are traumatised. So as far as I'm aware from this presentation, I can take some questions away, and if I can have some details, I'll be able to sort of answer that a little bit more thoroughly. Within NHFT and with schools and with our GPs, with our health visitors, perhaps if they're still involved with Sure Start, so they social services, so there's going to be a lot of our partnership agencies and supports that might help you in that first sort of step, or even way down the line if we think that our child has PTSD or remains traumatized from their loss. So there are some families in grief organisations that might be able to help us do that. We do have, you know, our own child family teams within NHFT, but I can't share that information with you so easily, as I'm not so familiar with that area, particularly within NHFT, and how you would refer or get access. But of course, there are many sort of supports and agencies. So ask that question, share, find out, and certainly I'll be able to get back to that question after the presentation if I can have the details.
No worries, Trudy. Thanks very much, and we'll make sure that the details are passed on as well. So the final question we've got for you today is it normal for a person to feel a lot of grief for someone they weren't very close to?
Yeah, really good question, and actually really important that, you know, we may associate. So it may be that our grief can be reactivated because it may be that we've got our own history of grief, so we still may, some of what's stirred up and what's come back into the here and now are perhaps feelings that we thought were resolved, partially resolved or processed, but they've become much more present because they've been triggered or reminders. So it may be that we have sort of shared understanding, even if we weren't close to that person. So there may be similarities with how that grief's been triggered by the relationship, even if we're not close, because the meaning may be very, very similar to ourselves, or you know, time, our value base changes over time. So how we think, feel and respond in our grieving process may alter over time. So our own story, our own beliefs and value systems may just become more to the here and now, even if the relationship specific elements don't feel that that's strongly linked, but there just may be enough reminders and associations of our own story, or another person close to us. So this may just become much more into the here and now, and we may, yeah, go back into a grieving cycle. Okay.
Lovely. Thank you very much, Trudy, for that really useful session, and certainly I think everybody's learned something about the grief process from that. I'm sure you'll join me in thanking Trudy for taking the time to join us today and to share her learning insights and experience. As you're aware, we are running a prize draw over the course of this week. So as I've mentioned, in order to enter the prize draw, you need to share your feedback for this session. So please click on the link that colleagues have put into the question box, so that we can just to enter your email address, so that we can then send you the feedback form. Feedback is a gift, and completing the form will only take a few minutes, and you have to be in it to win it. I would just like to say a massive thank you to the behind the scenes facilitation team, and finally a thank you from all of us to all of you for your amazing hard work, determination and commitment. Please check out the website for all the fantastic opportunities which are available during the week, and most of all, enjoy the rest of the week and stay safe. Thank you.
Thank you all. Bye now.